Saturday. Well, actually, happy Sunday. Welcome back, everyone. I'm Dr. Kimberly Madison, a doctorally prepared nurse practitioner. I welcome you to my channel. As you can see in the title, today we're going to talk about all the ways you can specialize in dermatology as a nurse practitioner. We're going to finish our conversation that we started last week about preceptorship and orientation. We didn't really talk about orientation, but we're going to talk about it today. So we'll continue what to expect during clinical rotations and working with the preceptor as an RN and then into an NP. And then because one of you hit me up, we're going to talk about what to expect as a Derm NP, but really I want to focus my attention on all the ways you can specialize in dermatology. As you can see, this is the Nurse Practitioner Entrepreneur Diary series. And so we will be coming on, I come on every weekend to talk more and more about derm. I talk about being a nurse practitioner, budding entrepreneur, and I answer your questions about dermatology. So I'm a nurse practitioner, and I specialize specifically in dermatology nursing education and research with emphasis on skin of color. I've been coming on every weekend for the last year. I started during Vlogmas to help me get this channel going, and it's been really great. I've come on every week. I was coming on live every Sunday. Right now, as you're watching this, I'm in sabbatical. And so I'm doing some batch content, and this was one of them. And I don't know if I'll resume live when the sabbatical's over in January. We'll see, but you can expect a video every Sunday. I drop articles on the Mahogany Dermatology blog every week. And I'm on social media every day giving you information. So if you're new here, welcome. I share my journey as a living case study in hopes that when we do have business prereqs and standardized courses in nursing, and so you do get some in NP school, but when it's more prevalent, that maybe someone will study my journey as a way to help you do things more efficiently and with more precision. Like I said, I have been doing YouTube for a year, but I've been sharing my journey on social media for 2 years through the Mahogany Dermatology blog. I'll go through all my affiliations later, but we always have a main topic. After I go over the main topic, we'll go over our weekly agenda, which always includes health and wellness, and that includes spirituality. In the new year, we'll start talking more about finance, financial literacy, and just your physical well-being. It's my belief if you take care of other people, then you should also take care of yourself. So I share with you in real time, and so I usually go live. But I like to preach batch content because it helps you prevent social media burnout. So I did this last week. I recorded on a Friday afternoon, and then when I scheduled this, so I'm using my computer, I'm going live on my YouTube channel. By the way, the first time you go live on your channel, you'll have to wait like 24-hour period to get approval. And then you can't go live on your phone until you reach a certain number of subscribers, I think. But anyway, I'm going live on my laptop. Now, last week when I did this, it was on a Friday. And then I ended it. Then I went back in and I changed it to scheduled. So then I scheduled it for Sunday. So that was the whole thing. I wanted to come back and tell you the experience because in the past when I've done scheduled videos, I use my camera, like my separate camera. But that requires like more, different, making sure the camera's charged, then setting it up, lining it up, making sure it looks good. All these things where just getting on my laptop with some lighting is so much faster. And so I always try to make things as simple as possible because that's how you're going to be most consistent. And so it did work great. And so this time, so last week, because it was live and it was public, because you have a setting, private, unlisted, public, I had it public. So someone came in and saw me. So this time I have it as private. I don't know if anyone can see me. We'll see. But when I'm done, I'll go back in and change it to public, scheduled for tomorrow. And then the plan today is to do at least 4 videos. And we'll see how that goes. And that will be really helpful. Let's just jump into it. I have so much to cover because I want to finish that conversation. I listened back to it, and there were some things I just want to clarify and then go in a little bit more detail. And then I've talked to so many of you this week. Thank you so much. I met one of you in person today. Now, you don't know me from social media, but you have a passion for derm. And just being able to talk to all you each week is so encouraging for me. So many of us get out here, we do work. I think parents would probably feel the same way. And you wonder, is anything that I'm doing making a difference? And teachers too, I would imagine teachers, and even as clinicians, we think that too, right? When we see our patients coming back without very many changes in the right direction. And so you can wonder sometimes if what you're doing is in vain. And so when you guys share your stories and your passion for dermatology, that just refuels me, one, to see that you're all in love with derm, but that you're being so transparent with sharing your journey and your concerns and your questions, and being willing to hear what I have to say. And so I just want to thank you for that. And so, yeah, all of you who've made purchases in the virtual Preceptor Shop, which is a collection of digital resources, I especially want to thank you for doing that and supporting the work. All of those, for the majority of the things in the virtual Preceptor Shop, they came from your questions. I find that after I've answered the same question, 5 or 10 times, that it's probably a good time to put together a resource. And that's actually my advice from my colleagues this week. When it comes to documentation, we can all create kind of smart phrases. And so when I find that I write the same thing over and over for a diagnosis, a treatment, an evaluation, then it's time to write a dot phrase. And templates too, even running brands and businesses. When you see you doing that whole automation piece, and the same thing with your life. We're going to talk about that in one of these videos about how to automate your life. And so we always start off with, I wish you guys were on so you could talk and ask your questions. And that's my dream, is that one of these days we'll go live. We'll do this thing I would like to call office hours, where we come on. I would love it to be like a whole cohort of students, and we just chat and ask your questions. And so one of these days I'll be referring to this video and the other videos that I've mentioned, and I'll be like, I never thought it was going to happen, or I never thought it was going to go like this. Okay, so I'm going to pull up our devotional, and it is seasonal. We are officially in seasonal affective disorder. I've talked many times about my own anxiety, and I think it's quite prevalent in our profession because of the work that we do, the responsibilities that we have. And it can be very managed, but I just think we don't hear enough about it. And so I've shared about it. I'm doing really good right now. And actually, this morning I had a brainstorming session with a new clinician we're going to bring on to talk about mental health in the Black community and with men. And actually, the topic, we're going to talk to him specifically about mental health. We're going to talk about feelings, what those are, kind of the differences he sees with treating women and men. And then more specifically about mental health and like addictive behaviors, which is super cool. So stay tuned for that. So let's get into our devotional, and then we can get into our topic, since that's what brought you here. And like I said, these are my beliefs. You can believe whatever you want. I just encourage you to take time out in your day, in your week, in your life, to make time for yourself. And that includes all the areas that we teach our patients are so important. So for this one, I use the Holy Bible app. There's a section on there, there's like plans. You can put in keywords. You can see the plans they already have, and it will show you a list of devotionals. There's typically a devotional, which I read during this, and then there's a scripture associated with it. In addition to the reading, there is an audio feature. So in case you or your patients want to use that, it's there. And this is a free app. I don't know if there's a paid version, and you can log in and kind of save notes and highlight and stuff like that. So this one's called Understand That You Are Not Alone. That one sounds familiar. Maybe I just heard this recently in another sermon. Okay. Understand that you are not alone. When praying for healing, it is very important to understand that we do not have the power in ourselves to heal someone. God is the one who heals, in the name of Jesus and by the power of the Holy Spirit. The good news is that if you're a believer, God lives in you. The first disciples of Christ were greatly used by God for extraordinary healings. Take this example in which Peter and John minister healing to a paralytic man. Then Peter said, "Silver or gold I do not have, but what I do have I give you. In the name of Jesus Christ of Nazareth, walk." Taking him by the right hand, he helped him, and instantly the man's feet and ankles became strong. He jumped to his feet and began to walk. Then he went with them into the temple courts, walking and jumping and praising God. Faced with such a miracle, people reacted with great admiration, and Peter explained, "Fellow Israelites, why does this surprise you? Why do you stare at us as if by your own power or godliness we made this man walk?" Then he added, "By faith in the name of Jesus, this man whom you see and know was made strong. It is Jesus' name and the faith that comes through him that has completely healed him, as you all can see." The first disciples saw all these miracles because they understood they were not alone. As we read in the theme verse of our devotional today, Mark chapter 16, verse 20, Jesus worked together with them, confirming the gospel message through miracles. He is the same today and continues to confirm his gospel the same way. The greater our awareness that Jesus is the healer, the more we will witness God's miracles. Miracle healings do not happen because of our personal efforts or good works, but because of Jesus' sacrifice at the cross. As we pray for healing, we must be aware of the presence of Jesus in us and trust that he will heal the sick. You can trust in the living presence of Christ in Jesus, the living presence of Christ in you. You do your part to share the gospel and pray, but he is the healer. He continues to confirm the gospel with signs and wonders today. Putting it into practice as you pray, practice the presence of Jesus, intentionally directing your affection to him and becoming aware of his living presence in you. Next time, we will learn about the importance of faith when we pray for healing. And our scripture today comes from Mark chapter 16, verse 20. And the disciples went everywhere and preached, and the Lord worked through them, confirming what they said by many miraculous signs. Amen. Okay, so last time I talked to you all about your clinical rotation as an RN, and I said shadowing, and I want to correct that. So when you have a license, so when you shadow, typically that's reserved for people who don't have licensure, a certification, or privileges to practice at that particular setting. And so in most cases, these are students. You could be a grade student in grade school, or even in college, maybe even a nursing student. Even now, you might be an NP and you're shadowing another Derm NP to get exposure, but you don't have privileges at that setting, so you might not do anything hands-on. Typically, shadowing is associated with observation. Once you are in nursing school and you go do your clinical orientations, you are working under your your student license, student status. And so there's paperwork involved, and you have malpractice insurance. And so there's that kind of coverage and protection. So yeah, at that point, it's very hands-on. The degree to which you're hands-on is going to depend on your school and that place that you're doing your hours. And I believe for the most part, you can do everything except for there are usually some criteria about IV medications and pushes, and that just might mean you might need to be supervised. And then as you go through your orientation, it can vary on like how much supervision you need or how many times they need to see you do something before they're comfortable and confident you can do it on your own. So that's one thing I wanted to clarify. And then you will work that. So the preceptor that you have at the hospital, like I said, so when you are the preceptor, you do get paid a little bit, just another couple bucks. So that's another way you can make extra money, working at night, working as charge. And then depending on where you work, like where I used to work, they have like opportunities for you to do research. And so when you participate in those, you get paid also. You get paid extra, pretty good amount actually, a few thousand. So that's as a student nurse. And then as an NP, it's the same thing. You're going to have a preceptor. Your school might have that for you, or you might have to find one on your own. So when you physically show up, you and your preceptor have agreed to how often you're going to come based on what your school says you need in terms of hours. Again, it's going to be very hands-on. So it might be a progression, like maybe the first time you just observe, and then maybe you start doing things like looking up the patient in advance, looking through the EMR, going and getting the history and the physical, and then presenting that case to your preceptor. So you might go in the room by yourself, introduce yourself as the student NP, and say, I see you're here because you're losing some hair. And then you might go through when did it start? Oh, so when I was in NP school, we learned old charts, origin. So when did it start? Location at the crown or the vertex. Duration, it's been 6 months. Characteristics, it was thinning and now it's bald. Charts, or maybe it's carts. You'll have to remind me. I don't use that in practice. But then it's so where did it start? Where is it located? How long has it lasted? characteristics, things that make it better or worse, the treatments that you've tried, if you have a history of this, any side effects, and any other associated conditions when you have the hair loss, like itching, burning, pain. And then you might go through their history. And so, any other diagnosis that you have, any other medications that you take, allergies, surgeries, family history. If you're in primary, when you're in rotation, it's going to be primary care. And so you're going to talk about vaccinations, all your preventative measures. Depending on their age, you might ask about screening, like mammograms, colonoscopies. And then other providers, they might see pap smears, eye doctors, dentists, especially if you're talking to someone who's been diagnosed with diabetes. So you're going to get your H&P. And at this point, you have really, and so then, always, always. So then you're going to go through, I can't remember if I said allergies. Then you're going to do your examination. So you can do the review of systems, kind of go through from head to toe, cover some of the main things that might be associated with what they came in with. And then you can do your exam. By the time you get to that point, you have a good idea, and pretty much from what they told you, of what the problem is. Your exam is helping to kind of confirm that. Then you share with the patient what your diagnosis is. If you have more than one that you're thinking you're differential, you can say, most of the time when people come in with, the symptoms that you're experiencing and the what I see, this is usually the case for someone your age and your history. And so this is what we're going to go with. But in the back of, but I'm also considering blah, 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 blah. And so for this, I'm going to, prescribe or recommend, or these are the options. Which one do you feel more comfortable with? Which one's more appropriate for you? So that's your shared decision making, giving the patient a chance to have input, making sure that whatever you're recommending fits their lifestyle, their budget, their preferences, their level of comfort. And it's a chance for you to also start to begin to evaluate if they understand what you said, getting them to put things back in their own words. Then you're going to pick your treatment. You're going to tell them when they should notify you in case there's any side effects, common side effects, what to be alarmed about, what not to be alarmed about, and when to come back, and how to schedule that appointment. Is it with you? Is it with the front desk? Is it online? Does the next visit need to be in person? Can it be online? And then how long to typically, how long to expect to when to see some, changes, improvements, those kind of things, kind of setting expectations. And so as the student, depending on the setting that you are and that provider that you're working with, will determine how much of that you do. And so you might do your presentation when the provider comes in the room, or you might step out and go do the presentation. And it can be a little nervous, right? Especially when it comes to that diagnosis. I think I had so much imposter syndrome for that for so long. And that's where the differential comes in. And they have some acronyms to help you remember, like to make sure you always rule out like cancer, infection. There's like a little saying for that to help me, the red flags that you want to make sure you rule out. And so in your differential, especially as a student, your preceptor is going to want to hear that you're thinking about those. So you can mention all of those things, and then what you still have questions about that you might order a diagnostic for, and what you can do for the patient right now. So that, it's all for learning. So certainly in the beginning, when you're first in that rotation, the whole thing is for learning, but it's expected that from day one compared to the last day that you've seen some progress. And so a good thing to do is to go home that day, go through your notes, and look up some of the most challenging cases, because that's what's going to stand out to you when you can associate what you're learning with something you're doing. It's going to give you another wrinkle in your brain that's going to separate the lessons. And that's where your clinical rotation becomes so valuable. So when you're in orientation as an RN, my number one advice is that you can walk away with, regardless of where you do it at, regardless of who your preceptor is to create your own brain or your notes. And so I started in the ICU, and the way they taught me, pretty much the way you start, whoever you start with, is gonna either help shape you or be something you have to break later. But pretty much the way I learned how to create my notes day one is how I continued to create them as a nurse. Wherever I worked, even as a traveler, and so if you can walk away with that, that's great. So that's going to be somewhere on your paper is going to be somewhere something about, what brings the patient in, that chief complaint. What's their history? Um, what's happened during the course of their stay? Any complications, any tests that have been positive and need to be followed up with, things that have been ruled out, like the big ones. Like if they came in with chest pain and you've been able to rule out PE, that's a good thing to mention. And you'll learn throughout your practice what you need to bring up and what is not what can be read in the chart. And also what then you need to tell that next nurse where they're going to pick up where you left off, and then the review of systems and a place to keep track of what you need to do for your shift and what you need to tell the next nurse to do for their shift. And so that whole continuity of care, I remember one of my colleagues was like, it's called continuity of care for a reason, because you can't do everything. Now, there are going to be some people who, everyone works hard. Let's put it like that. Everyone who wakes up and gets dressed and comes to the setting is working hard. Some people don't work more than is required. But for some of you, you will have to be told to stop and to, share the love. Let someone else pick up where you left off. You don't need to stay another hour or two behind to do something that you can pass on to your next shift. And so it's really great whenever you get the chance, either as a student or working, to work both shifts, especially in the hospital, because then you get to see the full picture, like how everything works together. So as a night nurse, what I understood my role to be was to support day shift, because they have so many things to do in the day, from getting the patient out of bed, bathing, depending, meals, procedures, meetings. And so they don't have time to do things like stocking or reading through all the documentation. So at night, that's something I can do, right? And all the little things that they can address during the day, I can address at night. The little things that bother the patient that the day nurse just can't, it's not a top priority. I can try to make it a top priority during my shift. And so that's how I think being able to have that experience is wonderful. I'm not a big fan of working on that 50-50. I think one or the other, it's tough, the back and forth. All the data suggests that, especially the night shift part. But I just think it's a lot harder to go back and forth all the time. It's hard to have a consistent schedule. But that's just me. Everybody's life is different. So yeah, at the nurse level in orientation, try to walk out of there with a brain. The first one you have is not going to be that great. Start with someone else who already has one. And then as you go through your rotation, see like what would help you. And so one way to help when you're writing or you're taking a report is write things that are like charting by exception, for example, is something you might learn. Write down all the things that are positive, like a positive, right? Or like, so I'm saying positive, but so for instance, you don't have to write down everyone who is ANO times 4. Maybe you just write down when they're not ANO times 4. If they have an IV, then you put that. If they don't have an IV, you don't write anything. If they're continent, maybe you don't write anything either, except for the last bowel movement. And so that's how you can get through charting really quickly. You can in your textbook, they have all the abbreviations for like, NPO, NPO, antibiotics, things like that. So if you learn that, you can write a whole bunch with very little text on your paper, and you can come up with your own. Just the main thing is make sure it's clear and legible. I find that even though it's not my notes, if I come behind you and read it, and even I can't make sense of it, in most cases, that nurse had a very hard time giving report, and the nurse receiving report didn't understand what was going on. And so when you're working with preceptors, you certainly have a lot of goals to see a lot of, to do a lot of skills, to see a lot of experiences. And that's a thing you can verbalize and say, can you help me create a brain? And then if it's a Word document, which is my recommendation, if you can get a copy of someone's Word document version or make your own, this way you can make adjustments to it. I always use blank paper, but a lot of nurses did use a Word doc and they would adjust it or edit it. So that's one. Some units will have one, so for someone like me who already had a system and there was like a unit I worked on where they had their own. That requires me to be a little, you become creatures of habit. And so it would just take a little bit of adjustment to get to that. But those can be super helpful. If you work on a unit and you're part of like a practice council, or you think it might help your unit, that's a recommendation you could make. Especially if it's like a specialty unit, you can say, hey, can we come up with our own report and streamline communication, make sure we hit all the high points, and it might make things even faster. So that's a tip. And then, even though you're assigned to your preceptor, keep a track of what it is you want to see or do, because maybe your preceptor will know their other colleagues. You can talk to the charge nurse, and they'll know which patients have certain conditions and things that you can see. So maybe you haven't been able to place a Foley, and you know that a patient's coming in who's going to need one, or is going to need their central line replaced. And so just tell everyone, hey, at the beginning of the shift, if you see this, this, and this, please call me and I'd love to go see that. So that's how you can increase, what you get access to during your rotation, instead of just depending on that one preceptor. Then at the NP, so when I was at RN, so that's rotations. And then during orientation, you'll be again given a preceptor. And so now this part of your training is to prepare you to practice on your own. And unfortunately for me, when I was in the ICU, I did have two preceptors, one assigned for the day, one assigned for the night. Super smart nurses, like brilliant, and they had really good relationships with the other nurses on the unit. But I didn't work with them all the time. I think in that time period, I worked with over 10 to 20 different nurses. And that makes learning really hard, because the first half of the shift, you're really learning that nurse's preferences. And like everything else is almost secondary. The patient care, all the things you think you're there for, it's the nurse. And so every time you switch nurses, you are starting over from scratch. And also, I would never get the same assignment. And so every shift I was starting over, not only with the patient, with the nurse. And so the beautiful thing about when you get the same assignment is they don't have to update you on everything. They just have to update you on the things that have happened in the last since you went home. And so that's super quick and fast. And so you can hit the ground running, the patient. It's just a smoother start and a smoother shift, and a more expected time when you're going to finish your shift too. It's not always possible, but it is the goal. And then when you get to, so now you're in orientation, you're with a preceptor, and they're going to steadily and quickly work you to being on your own. And so the focus there is going to be on numbers to call, people, some things you weren't exposed to as a student, making those phone calls, receiving lab results, calling family or the doctor or whoever the provider is about those results, and really just how to organize your shift. So you want to work with that preceptor and say, how early do you come on? What do you do when you come on? Are you going through all your patients? What are you looking up? How do you see the orders? And how are you better prepared to get that report? And basically, when you get report, they shouldn't be telling you everything. Well, so let's put it like this. When you get report, that's for you. And so you can't say, well, they didn't tell me this. The thing is, you should say, did you ask, right? If someone's saying, oh, they refused this medication, and you say, oh, did the nurse say why they didn't refuse it? And you say, they didn't say. But the real thing is, did you ask, right? Because now it's on you. It's your 12 hours. You can't no longer blame the last shift, because as soon as you sign off on a report, you claim responsibility. And so if they didn't tell you something, if you didn't go look at it and put your eyes on it yourself, that falls onto you. So my advice at that stage, at every stage that you're giving a report and you don't have someone else to depend on, is to make sure that if right now something were to happen with that patient, do you know why they're here and what their medical history is in terms of like the big ticket stuff? And so I worked in cardiac, so I want to know cardiac history, things like tele, can they walk, and are they oriented? Like the main things. If a bed alarm goes off, do I need to think about that being my patient? Are they oriented? And like the big stuff. If they had a drain, if they have a surgical wound, are they on a medication that's running? Does the chemo nurse need to come? Is the family pleasant or very involved? Like some big stuff. But the main thing is if there's a code right now and I go in there and they ask me, why is this patient here? Can I tell them the main points. They're here because they had chest pain. So that now that they're having chest pain, we don't need to be alarmed because we've already, started the treatment for that. Or we do need to be alarmed because they've never had chest pain before. Like, it's a different level of urgency. But I can't tell you how many times you look at the nurse and they don't know anything about why the patient's there. You should always know why your patient's there at the minimum. So that's that part. So yeah, so now you're in orientation as a nurse. You're learning basically how to structure your shift. Your focus is on, oh, am I going to, hurt the patient? And that's a good thing to think about. But you really just want to be able to figure out how to organize your shift from each hour and keep track of your task. So you have task on the computer and you might have task on your notes. You just want to make sure, how can I be organized and how long should I expect before I move on to do something else? Because everyone works in patterns. And so your preceptor can help you identify a strategy and structure that works for you. So that's how I would say, that would be my advice for that period of your training. And then just don't be afraid to ask questions. This is a really good time to go over policies. And so when you're actually working, sometimes it's hard to go over policies, but sometimes it's not as long as you think, especially if you have navigated that website before and you know like how to get there quickly and how to search in the search bar. And then if you've read policies, then you'll know how to get to the portions that you need to. Otherwise, just take it home and read it. And yeah, be familiar with them. So now we're moving on to NP. So now you're in your clinical rotation. This is where you have to own your education and just have your own little plan on how you want to progress yourself. And I think if you present that to your preceptor, they'll probably be on board with that, to see that, you're taking away one less thing they have to think about. And they'll look at it and they'll say, yeah, this is a great pace, or I don't know if that's going to be a good idea because of such and such. Or if they say, well, why don't we just play it by ear? You'll be able to feel out how they respond to that. But I think if you take the initiative and put something together like that, they will be willing to support you because everybody understands it's your learning. And so you need to take ownership of that. So at that phase of your learning, my advice would be, again, I know your focus is on the patient, but I want you to be focused on your practice. So ask that provider, when do you start looking at your patients for the day? How do you know how many patients you're going to see? How are you preparing? Are you going through every single chart? And same with the nurse at the bedside. Some people will come in an hour before. I did that a couple of times, but I'm going to be honest with you. I really just showed up at 7, and then I would take report after that. And because in reality, sometimes you do get patients that just come out of nowhere, especially in the hospital. You don't get report, or you get a terrible report. So it's basically just like them walking off the street. I did work in the I have worked in the ED before. I have gotten patients coming straight from PACU, and there's just no report. Patients coming directly from home. Again, the report that the transporter gives you, which can be limited. If the patient is a poor historian, it can be limited. So you can't always count on having like a full chart and knowing everything when your patient walks in, but you're just going to go through your system of like what brings you in, getting some history behind that, and then their review of systems and your head to toe. Every single case is going to be like that. So the sooner you can kind of master that, it doesn't matter what walks in the door. And you will get to a point where, every patient is the same because your process is the same. Okay, so now you're the NP, you're working with that preceptor, and my questions, yes, you're going to ask questions about diagnosis and treatment and all those things, but also since you have that expert there who's navigated things, you want to figure out what do you do the night before? What do you do that morning of? What resources are you using? How do you organize your computer so you can get there quickly? If the place you work at just has one login for the medical record and one place to check email, that's going to be easy. But if you have a whole bunch of little things you have to check for drugs and insurance and education, then just figure out how you can organize it in your computer so your brain is organized. When do people take breaks? This is in every setting. Is it an official break? Is it a real break? And as a nurse, depending where you work, that might not be a real break. You work 12, 13. It's a 12-hour shift, but you come in early and you stay late, because you're given a report at 7. That can take 30 minutes. So it's always more than 12 hours. And if there's an emergency, there's a code, if they just dropped off someone, it's never 12 hours. And so not getting a break, not stopping to urinate, those are real things that happen. And so anyway, as the NP, you talk about the break. Do people eat here? Do they go out? Do people sleep through their break? Do they work through it? Whatever the case. And then how many days a week do you work? How many hours do you work? So some people will work your typical 8 hours, 5 days a week. A lot of people will request 4 shifts, 10-hour days, especially if they just left the 12-hour shift life. They're kind of used to that, so they don't mind it. It even sounds pleasant because it's like, oh, it's not 12, it's 10. And at least I don't have to work 5 days, I work 4. And so you'll see that. I know some people work 3 days a week, still full pay. So there's so many options. So these are chances to kind of learn about the different options. And then documentation, how do they optimize their time? Are they using smart phrases? Are they using an AI tool? Is it permitted? Things like that. Policies, compliance. I think those are some really good questions asked. How does billing work? Those are, especially if you get to do a derm rotation, there's so many questions about billing and how people get compensated. It's probably a lot easier to have those conversations when you're a student than when you admit that you want a job there. Or even now when people are getting offers, people are going to be more open to telling students than their peers who they might see as competition. So yeah, I think that. So as far as a nurse, when you do orientation, you're going to do things like med surge, maternal health, so OB, L&D. I got to see some live births, but depending on where you go, they might not happen. You can't plan them. Got to see some C-sections. I feel like I did home health during my nursing school rotation. I feel like I went to hospice, like an actual hospice place. ICU, and I think the first day that we were there, someone died, and so that's when I learned postmortem care. And I just thought, even that first week, it was just a lot of death. And I just thought it was so interesting because I was like, so many people, glorify the ICU, and I was like, man, I haven't heard anyone talk about the death part of it. And there is a lot of death in the ICU. There's a lot of death in healthcare in general. But that stood out to me, and at the time, I just loved the ICU so much. And so, yeah, those would be your rotations during nursing school. I'm just trying to think about all the classes. You'll have then you go to lab. Sometimes you go to lab and do health assessment. So that's like the stuff that you're thinking about, like you're learning how to do blood pressures, place Foleys, catheters, and all the procedures that you can do at the bedside. That's what you'll be learning there. As an NP, the kind of rotations you'll do depending on your program. Certainly do primary care. If you're FNP, you're going to do peds rotation, women's health. Women's health can be a women's health provider, like women's health, like OBGYN, a doctor, but it can also, or a PA that works in obstetrics, or it can be a women's health NP, but some FNPs also work in women's health, and some primary care providers also do women's exams. So you just have to ask. So you'll get to do that, and depending on your program, you might have to meet on. So because my program was distance learning, so we have our classes are all on the computer, and then there was 2 or 3 times we had to be on campus, and we would learn certain skills like the pap smear and the pelvic exam, breast exam, like all those kind of things on campus with real people who agreed to help us learn. And actually, when we did the pelvic exam, that lady was the instructor on her body, and she would talk about her body. She taught me one of the things that has stuck with me the most in terms of stop using the word spread your knees, because I stopped using it. So I think, is it spread your knees? Yeah, spread your knees. I stopped saying that. She said, because that can be traumatic for people and triggering. And so instead, what I say is, can you separate your legs? Do I say separate your legs? Separate your legs. I can't remember. Now I'm trying to think which one was the triggering one. I think spread your legs is this triggering one. And so I start saying, separate your knees, or can you bring this leg out? Stuff like that. And so I thought that was super helpful. And anyway, so we'll go on campus with, I think they called them actors. I don't remember what they called them, but real people. We work on their body, so all the kind of assessments. And then you have a standardized So that was the standardized patient. It was a real person. In nursing school, we had the mannequins, and the mannequins have features so that they can breathe, that you can hear a heartbeat, and then the instructors would be in the back, and they can talk and make noise. So it's like simulation. And then in NP school, we go to the lab, we learn those procedures and examinations, you get tested on those, like in person. And then when we're not there at home, you would record yourself doing the exams on like friends or family who agreed. So in that case, I think I did all mine on YouTube. So I don't know, maybe my computer had a recording feature. So I would record myself doing the exam like on my mom. And actually I have a good friend of mine, Shannon, she agreed to do it and be my patient. And then I would upload it to YouTube under unlisted because no one can see that video unless you give them the link. And so then you would send that link into your professor, they would watch it and grade you. And so today I forgot to tell you, I went to, I'm in Houston. There's a National Black Nurse Practitioner Association. They're based here in Houston. And today they had their scholarship brunch, and I got to meet them for the first time in person. And my mentee, who just graduated, ceremonies next week. She wants to be a neonatal NP. She already got accepted to the NICU. And anyway, she was asking these questions because, like I said, she wants to be an NP, and she was asking about the difference between in-person and distance learning. So what I'm explaining right now would be the distance learning format, because there's some misconceptions that if it's an online program that everything's online. The only thing that's online is the lecture. Everything else is going to be hands-on. And you have to, either the school's going to help you get a site and a preceptor, or you have to do it, or there's some combination. And before I forget, some school, so if your school makes you do it yourself, I just emailed my school and they gave me a list of preceptors because they have to have contracts with whoever you're going to get precepted by. So they keep a list of that. I don't know why they didn't just automatically share it, but I just emailed them and they gave it to me. But one of the ladies we talked to today, she said the school she went to, they just provided it. I think she went to Texas Southern. And I'm trying to remember if she went to if that was for her FNP though. But yeah, just ask your school. And so then we would go in person however often they wanted us to get tested out. So you do that with the real people, you get tested. Sometimes you're by yourself, sometimes you're with other people in your cohort. You do the whole examination, then the instructor comes in, they're listening, or they come in and they want you to give some answers, and everyone gets a role. This is even starting in nursing school. Everyone will get a role, and every time you go to simulation, you get a different role. Sometimes you're a primary nurse, so you're going to be responsible for maybe a lot of information. Sometimes you're the family, maybe you're the second nurse or the charge nurse. And so you get to have these different opportunities to see the different roles that are available and what's required of those roles or expected. And then, so that's rotation. And then rotation as an NP is just going to depend on that provider's schedule. And so orientation. Now, orientation in both settings is, again, you preparing to work. So as an NP, again, it's like, when do you prepare? When do you look at the patients you're going to see? Do you start the night before, the day of? And when you're looking at that list, what are you looking for? The patient already put in their chief complaint. And so if it's something you're familiar with, you might be like, okay, great, that's going to be a short visit. Or, oh, let me look this up before they come in so I can have a few ideas on what I think. Maybe I haven't seen this very much. Or I'll wait till they come in and hear more about it because this is kind of a vague complaint. Or, oh, this looks like might be a long visit. So let me talk to the front desk. Maybe we can make some changes. Or, oh, so-and-so canceled. Let me call and see what happened. Or, oh, that's an opportunity for me to call back some people and talk about results. So yeah, those would be questions I would ask during my orientation. And anything you're just not sure about. But pretty much every day, you just want to feel like, if I was going to be on my own tomorrow, what is it I feel like I need to know still in terms of structure? And like, when I have a question, where am I going to go for that answer? And don't keep everything in your head. Put it somewhere where it's organized and you can quickly find it. And that sets you up for success. So if it's going to be a little notebook, what happens if you forget that little notebook? And by the way, speaking of notebooks, I'm a big writer. So when I was a nurse, I always had when I was a student, I had a little notebook and I kept that in my pocket. When I was a working nurse, I had a little bit bigger notebook and I kept that because especially the patients are there for weeks, sometimes months. And so I just would keep that with me and update my notes. That's another way to get through a report really fast. Even now when I see the same patients, um, I set my notes up so that when I see the patient, I can quickly see what it is I'm following, and what my thought process was. And if I wanted to do something another week, another 2 weeks, what I need to follow up with them about or the nursing staff. So I set it up to support the way I think and how I like to be organized. And I think that's really it. I think when you're in orientation as a provider, it's all the big stuff like who does what, um, and when. So hopefully I've answered all your questions about that. And so when it comes to specializing in dermatology, I was telling a young lady I met today at the brunch, it's just like you looking to get into derm as an NP, like taking care of the patient, because that's all you hear about, right? In school and around you is this one role, this one opportunity. Well, you can think about teaching because, where else were you? School, school and clinic. So what are the roles there? Professor and NP. So it's not unusual that that would be all you're thinking about. But the beauty of my journey personally, and it taking longer than I had planned, is that now I've been exposed to so many things, and my mind is just like full of information that I love to share with you all. So, of course, when it comes to specializing in dermatology, of course, you can practice as a MA, as an RN, as an NP. The great thing about the MA and the RN route is there's no requirement besides being certified or licensed, whatever the role is. So that's a great way to get in. And then, of course, as the NP. Now you can teach. Now, when it comes to teaching derm specifically, I don't know that you'll find that in this school, like nursing school, NP school, but if you like are part of an organization and their education committee, or you're on a board and the board members do teaching, then of course all your teaching is going to be in derm. You can reach out and tell people, hey, if you wanted someone to come and speak at your conference, at your event, at your members meetings, and you specialize in derm, you can do that. Someone was on Facebook last week talking about how she's not adjunct faculty, but a lot of NP schools will have guest speakers come in to cover like other topics. And she said she does that one. She doesn't get paid, or she doesn't ask for compensation. But that is certainly something you can ask for. Conferences, when you submit abstracts, when you speak for other organizations, those people are getting compensated. Okay, so those are other ways you can teach in derm. And medical science liaison, so you can support the clinician. So maybe you're not the one seeing patients on a daily basis, but you're supporting the clinician because the clinician's busy taking care of the patient, so they don't have time to read literature, read research. So you get paid to read. You come in and whether eating lunch or whether in between patients, you come in or you take them out for dinner. You come in and you tell them about these new drug indications, who the right patient, contraindications, common side effects, adverse effects, any labs that need to, or diagnostic testing that need to be done before you can prescribe it, what those prescribing recommendations are initially, and then maintenance, all the little things that you would tell your patient, all the little things you need to do, they're going to do that for you. The APP, very similar. They're in a role to support the clinician and to be there to tell you information that you're not able to get on your own because you're so busy. And now for that in particular, I talked about it before, and it might be changing. But traditionally, the medical science liaison was a pharmacist. So, pharmacists have their doctorate. There are nurse practitioners getting in that role. I know a DNP trained nurse who does that. And I recently heard like a PA was doing that role. And so I don't know if they have it. They might have they might have a doctorate too. So from my understanding, you have to have a doctorate to do the medical science liaison role. And so hearing that a PA does it too, and the NP and the pharmacist, that's good for you. So those are some other options. And I love the idea of getting paid to read and to teach in this capacity, because teaching doesn't have to, like I just said, doesn't have to just be at the university. And so this is another one that you're not going to hear about in school. You can partner with cosmetic chemists. So I've talked before about my relationship with Eunice Kofi Obeng. She is the founder of Nueki, which is an innovative skincare line for people of color. She's a cosmetic chemist. She graduated from FAMU. She's originally from Ghana. She had a beauty and wellness event this summer in Hampton, Virginia. And so, yeah, she's been doing this for a very long time. So not only does she have the skincare line, she has organizations coming out for chemists, especially women of color in chemistry. And so, yeah, learning about her, and you can partner with them. So let's say you have been you don't even, who cares how much practice you've had? You can either have practice, direct experience. You can learn about the research. You can identify what kind of products are out there or not out there that meet different kind of populations. You can work with them, come up with new products. So if you're in the entrepreneurial lane and you want to come up with products, that's someone you can partner with, right? You don't have to start from scratch. They can bring a wealth of knowledge to what you're trying to do. And yeah, you can be in the market. And then you can work with medical illustrators, something I look forward to doing, to increase the number of skin of color images in textbooks and all the ways that we learn, right? Textbooks is just one of them. But that's another way you can be part of the industry. So whether you're NP or not, that's actually a degree. And it's in Maryland. I can't remember if it's Hopkins or one of the University of Maryland campuses. But that's a degree, medical illustrator. And they have a whole, maybe I'll write an article about it. They have like a whole kind of initiative out there on putting skin of color images. Like there's a collection of them. And I think you can access them for free. After this is over, I'll go put the link in the description box for you. And then I'll talk about it again at length at another time. But that's another way you can be in derm, is to, again, this is another educational route, through textbooks, through images, digital images, so many ways this can be done, especially in dermatology. And for so many people, peds, adults, like I can go on and on about how you can use imagery to illustrate a topic for patients and clinicians, and how fun that can be. You can speak for industry. So we know this is true, and you get paid to do that. Some people do it as a side hustle, and some people do that as their primary 9 to 5. It was not really a 9 to 5, and there's some travel associated with that. Just like the MSL and the APP liaison, you get assigned a region, and you get paid to travel, and so that would be another way you can have the travel life as a clinician. You already know about travel nursing. If you travel as a provider, it's called locums tenens. And then these roles also have some travel. If you work for pharma and even companies like, I don't know if it's Medline, but like those companies, you can work for them and you go around and you teach other people about their products. So it's another travel opportunity in and outside of derm. This is just medicine in general. Lead nursing research. That's something you can do to improve patient care in our practice. You can work. So you can work for companies tech companies. I know nurses work at Microsoft. This week I learned that Verizon and Best Buy have sectors for healthcare. So if you're an entrepreneur, even if you're not an entrepreneur, but it's great if you are an entrepreneur, you might go over there and see something that you can contribute to or benefit from. But yeah, research is a great area where you can help with in dermatology. You can practice in dermatology. You can have your own research clinic. You can go work somewhere where they're doing research. And there's so many things to do research on. And then you can increase access to care, of course, So you can start a practice. This is kind of back to being the clinician. Brick and mortar, you can invest in people who want to have their own practice. You can invest in telehealth or aspects that allow providers to deliver care. So maybe you don't do the care yourself. Maybe you invest in people who want to start their own practice. Maybe you invest in a telehealth practice. Maybe you invest in helping increase better broadband or apps or kiosks that helps that employer get patients signed in quicker. So maybe instead of them going to the front desk and having a person they have to pay to get them admitted and signed in, you have a kiosk. So one of my mentors, she was a pediatrician, and she had some staff, and then she ended up not having any staff and running the whole thing by herself. She had been in the Army before, so she had it down to the minute. And so and everything was like electronic. So they either text her or everything was on the computer. techs and this kiosk. And so you didn't even really need to be waiting in the building. If your appointment's at 9, you just wait in your car till 9 o'clock. You come in, you get in the kiosk, you sign in. She brings you back to the room after your visit. It was like, say there's like a 5-minute visit, 5-minute grace period in between visits. She knew down to the second how long it would take her to take off the paper, put a new piece of paper, wipe down the counters, and get ready for the next patient. And so it definitely can be done. I see people out here creating apps that can help. I don't know they're all apps, but they're using AI to answer phone calls, and it's really good. It's better than like when you call like a business and you have to listen to, you know, if you're such and such, press 1, da 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 da, press 2. Like it's really, really intuitive. I can't wait to learn more about that because I think that'd be really beneficial for people in running medical practices to answer some of those kind of routine questions. So yeah, those are all the ways you can support someone who's running a business. I've already talked to you about some of the problems and how you can position yourself and present proposals to people who own practices on how you can help them. First of all, listen for their problems and their pain points, and then figure out how you can solve one of those and become an expert in solving that. And when you become an expert in solving that for one person, then you just scale that and you can solve it for everyone else because they're all going to have the same problem. And so you don't have to directly be the person delivering it. You can be the person overseeing it. And even if you start your own practice, then have the end in mind. The end in mind is that you have people working for you. And so, again, that's how you can specialize in dermatology and not necessarily be the one seeing the patients. So I hope I've covered it for you. For me, I'm going to come right back on and film another video. But for you, I'll see you next week. I have a couple minutes left. So remember, go out and check out the Mahogany Dermatology blog. This week, I dropped my favorite article to date, my most prized article on essential dermatology textbooks and skin of color. As I mentioned last week, we talked so much about the lack of diversity in dermatology. And while that is true, and there are a lot of areas where we can make improvements, we already have some work that's been done. And we already have available resources. The question is, why aren't they being required or recommended? And so in this article, I give more than 10 textbooks in medical, surgical, cosmetic dermatology, including pediatrics. There's one in there by a licensed esthetician, Asian skin, dermoscopy, pigmentary disorders. Yeah, it's a really great collection. It really helps show my motivation for Mahogany dermatology and where I'm going forward. And so I can't wait to share more with you on that. I actually am going to submit this for the focus. I told you I want to be in that from here on out. I want to have a column in there every single edition. I already submitted one like a few weeks ago. I haven't heard back. So after I finish with you guys, I'm going to email them to find out if it's been accepted. And I want to submit this one too, see if it meets the criteria. But I'm really proud of this one. And we'll talk more about this in my next video. And then this week we dropped, the Melanin Initiative podcast. We brought back Demetrius Kirk. We're following his journey in our series called Becoming Doctor of Nursing Practice. He's catching us up on where he is. Now he can finally see the finish line, graduation. And so it was really nice to hear from him. He dropped a lot of really helpful information. And then as you're watching this, today we premiere Dr. Ani Adabang. She is a doctoral prepared nurse practitioner who specializes in primary and mental health, and she has a practice in Maryland. She does Precept. I didn't bring it up during the show because I don't want people to hound her, but I think it's okay to tell you guys. And then, so she'll be on there. So I've dropped 3 articles this week. I had the pleasure of being on again with Demetrius. He has his own podcast. He has his own business, doing quite a few things actually, but one of the things he does is he has his own podcast called Sound Leadership with DJ, and he was kind enough to invite me on. We filmed that in May. And at that time, my primary focus was on writing that book on how to get your first job in derm. I'm still working on that one. But since then, I've dropped the Dermatology Nurse Practitioner Starter Kit and From Bedside to Dermatology, Step-by-Step Guide for Nurses. And then, I'm in the middle of writing Dermatology DMP project ideas. And so it was great to catch up with him. And I repurposed that content and created another article on the blog. I always try to give you a social media tip. When you're doing this journey in the beginning, there's not a lot of people watching. But when you start to pick up a little bit of attention and pace, you can just refer people to your old work. That's what I do. And so happy to repurpose content whenever I can. And he was kind enough to give me the file. So I've uploaded it on this channel as well. Something you can ask for. And the third article I dropped was put a compilation of commentary that I put out on LinkedIn. I'm on LinkedIn a lot. Like I said, it's more scholarly, really more intellectual conversation and more conversations than you're going to have on Instagram and all the other platforms. And so good friend of mine, Dr. Farah Laurent, and Rachel Dumas, who is a graduate student. Her background is informatics and maternal health. They were on Farah's show and they were talking about entrepreneurship. And they dropped so many gems. And I had a lot of comments to share. So I compiled all that into an article on the blog too, talking about entrepreneurship. And I put a lot of emphasis on why I think you should start your own internship if you're an entrepreneur and some tips to do that. So we're going to wrap it up. Thanks for watching. I'll see you next time.